Good morning everyone. Today I'll be speaking on ventilation and weaning strategies in patients of acute liver failure. So starting with the definition of acute liver failure. Acute liver failure is a clinical syndrome which is characterized by rapid deterioration in the liver function resulting in encephalopathy and coagulopathy in patients who don't have any pre-existing liver disease. The first definition was by Trey and Davidson in 1970, and today there are almost more than 40 definitions in the published literature. Most definitions agree to define acute liver failure by the presence of encephalopathy of any grade and coagulopathy of more than INR of more than 1.5 or a prothrombin time of more than 15 seconds in absence of any pre-existing liver disease. Further, the acute liver failure has been further subclassified depending upon the onset of jaundice, depending upon the time period between jaundice to encephalopathy into hyperacute, in which the time period is around 0 to 7 days, acute from 7 to 14 weeks, 7 to 26 days, and subacute, in which the onset is from more than 26 days. So coming on to the organ-specific complications of ALF, ALF is known to the most common organ involved in acute liver failure is neurological. It leads to hepatic encephalopathy leads to cerebral edema, which can lead to cranial hypertension, and it can also result in brain death. The other important system which is involved is the coagulation system. It can lead to unbalanced hemostasis and resulting from thrombocytopenia. The other important organs which are involved are the metabolic parameters. It can lead to refractory hypoglycemia, hyponatremia, hypophosphatemia, and hypokalemia. The renal system can also be involved because most of the patients, when they come to the emergency, they are dehydrated and they can be having AKI, functional AKI, which is most likely of pre-renal cause. Secondary bacterial and fungal infection can also be common in these patients when the patients are admitted in ICU. And hemodynamic wise, this patient tend to have hyperdynamic circulation and they are also prone for arrhythmias. So coming on to the main indications for intubation in patients of acute liver failure, worsening of the hepatic encephalopathy grade is the most common indication of intubation in this kind of patient, which will further provide them with cerebral protection, airway protection, and prevention from any aspiration. A small subset of patients, they also present with respiratory failure with hypoxia, in which intubation needs to be done. Few things should be remembered while intubating a patient with ALF. Initially, the assessment of the hepatic encephalopathy grade should be done along with the airway, breathing, and circulation. The other thing is, most of the patients before intubation, they are agitated, most likely in HE grade 3 or 4. So a proper airway assessment is not always possible in this kind of patient. So one should always be ready for an unanticipated difficult airway in this patient, and the patient should always be presumed to be full stomach, and a rapid sequence induction in this patient should be done. A very careful monitoring of the hemodynamics should be done before intubation, because these patients tend to have brittle hemodynamics, and any brittle hemodynamics because most of the patients are dehydrated and all the anesthetic drugs are known to cause cardiac and respiratory depression. So very gradual and titrated doses of anesthetic drugs should be given for intubation. Now, as we all know that intubation response is one of the strongest response in the body, so an attempt should be done to blunt the intubation response before the intubation. This can be done with a bolus dose of around 50 to 60 mics of fentanyl, or with 1 to 2 ml of lignocaine before intubating the patient 30 seconds. The drugs, coming onto the drugs used for intubation, the standard anesthetic drugs are used like narcotics, sedative, and muscle relaxant. In narcotics, fentanyl in a dose of 1 to 2 mics per kg can be used. Sedative, the most commonly used sedative is propofol in a graduated and a titrated dose of 1 to 2 milligram, and rocuronium can be used as a muscle relaxant of choice in these patients. The ventilatory strategy in ALF should be aimed to provide a balanced pulmonary and cerebral needs. Most of the literature, they recommend lung protective ventilation in this kind of patients. To start with, a low tidal volume of 6 to 8 ml per kg of ideal body weight should be started. Normocapnia should be maintained, and the PaCO2 should be aimed at the level of 35 to 40 millimeters of mercury, and PEEP of 5 millimeters of mercury should be started at the onset. The aims of ventilation should be to maintain a saturation of more than 95 or a PO2 of more than 80 millimeters of mercury. Normocapnia can be maintained in the range of 35 to 40 millimeters of mercury. Permissive hypocapnia can be used in this patient, but only as a last resort in cases where they have a raised ICP. Prolonged duration of hypocapnia has not been recommended, and in the patients in whom hypocapnia is done, it should not be done for more than 1 to 2 hours in the range of 25 to 30 millimeters of mercury. Prolonged duration of hypocapnia is known to cause cardiac depression, which might further lead to hypotension and decrease in the cerebral perfusion. Tidal volume of more than 8 ml per kg should be avoided in order to prevent ventilatory induced lung injury. Now, most of the patients of ALF, they come up with a normal lung. The problem occurs when these patients have some superadded bacterial or fungal infections. In this patient, carefully this patient should be carefully monitored, and if the PEEP needs to be increased, it should be increased in a very gradual way with a continuous monitoring of the ICP. Role of PEEP in these patients: PEEP tends to cause increase in the intrathoracic pressure, which leads to increase in the cerebral blood flow and the cerebral blood volume, which tend to increase the ICP. So in patients who have secondary bacterial or fungal infections and a PEEP of more than 10 is used, ICP should be closely monitored using non-invasive methods like ONSD, pupillary size, and transcranial Doppler. Now coming on to the coming on to the monitoring and supportive care in the patients of acute liver failure. The monitoring includes the routine standard monitors like the electrocardiography, saturation, EtCO2. Invasive BP should be used in patients with hemodynamic instability. Urine output should be charted regularly. ECG and chest X-ray. A baseline ultrasound liver should be done to rule out any chronic liver disease. EEG should be done if there is any evidence of any seizure activity, and brain imaging should be done to rule out any intracerebral bleed or evidence of any cerebral edema. Initial lab functions will include the routine complete blood count, liver function test, and kidney function test. Arterial lactate and ammonia should be monitored. Culture should be sent in the form of blood, urine, and respiratory samples. Blood grouping should be done in view of need of transfusion for these patients. A baseline coagulation test should be done in the form of thromboelastography or extem or fictum, and viral screening for the etiologic workup. Now, the most important thing in ILF patients is cerebral protection. So we have to ensure that any kind of stimuli, whether be a verbal or light stimulant, should be avoided. This patient should be kept preferably in isolation and in a quiet surrounding. The head end of the bed should be elevated by around 30 degrees, and the head should always be kept in neutral position. This is particularly important when the patients, when the CVP line or a SD catheter is placed in this patient. Attempt should be made to make a very minimal, very less turning of the head to either side. Coming on to the ET suctioning should be done not frequently, but whenever it is done, it should be done gentle and minimal ET suctioning should be done. And a rough guide would be to see have a look at the airway pressures and then do ET suctioning. Generally, ET suctioning of once or twice in a day is enough if the patient has a normal lung and normal PF ratio. And prior to suction, the FiO2 should be increased to 100%, and a small bolus of sedation like fentanyl can be given, and lignocaine 1 to 2 ml can be given prior to suctioning. Glycemic control, these patients are more prone for hypoglycemia. Most of the studies, they recommend to maintain the blood sugars levels between 140 to 180 milligram per deciliter. Stress ulcer prophylaxis should be started, and enteral feeding should be started if there is no contraindication. Coming on to the neurologic monitoring, ICP monitoring in the form of non-invasive monitoring should be done. ONSD, NIRS should be recorded every second hourly. EEG if any seizure activity. Serum sodium needs to be maintained in the range of 145 to 155 millimole per liter. And ICP surges has to be managed with bolus doses of mannitol or hypertonic saline. Hyperventilation for short period should always be used as a last resort. And CRRT may be considered if there is persistent hyperammonemia. Renal protection should be done in the form of maintaining a good map of more than 65 millimeters of mercury and avoiding a positive fluid balance. Hemodynamics also, the map should be maintained more than 65 mm of Hg. Fluid resuscitation should be based on dynamic indices like pulse variation and stroke volume variation. Vasopressor of choice is norepinephrine in this kind of patients. Now, the mortality of acute liver failure is around 50 to 70% despite medical treatment. Hence, liver transplant remains the definitive treatment of choice for most of the patients of acute liver failure. So, coming on to the perioperative monitoring and ventilation in these patients, the most important and the most critical step in this patient is transfer of the patient from ICU to the OT. A lot of things can go wrong during this period. So all the things, I mean, we have to make sure that the patient is always shifted on a portable ventilator and not on a bag and mask ventilator, because when you ventilate a patient with bag and mask, the delivery of tidal volume is unpredictable, and this may lead to hypo or hypercarbia, which might lead to further increase in the ICP or decrease in the cerebral perfusion pressure. So, and the other important thing that is to be noted is all the syringes and all the syringes should have a proper battery backup in these patients, so as to avoid any discontinuation of any vasopressors or any inotropes or any sedation during the transport. After the patient is shifted from the ICU to the OT, the monitoring, the same lung protective ventilation has to be continued. Tidal volume, PEEP and FiO2 has to be titrated for optimum oxygenation. Ultrasound is used for the additional vascular accesses that we put in the OT. Advanced vascular access sheet is used in these patients or in all liver transplant patient, which allows us for a rapid transfusion of blood or blood products. Preferably 2 wide bore IV cannula should be obtained. Peripheral IV cannula has to be obtained, and invasive BP is used in the form of one radial artery and one femoral artery. The reason behind this is as the doses of inotropes or vasopressors goes up in this patient, usually we start with a dose of 0.01 to 0.02 mics of non-epinephrine per kg per minute. But when the doses go about 0.3 or 0.4 mics per kg, there is a discrepancy between the radial and the femoral artery. Hence, it is necessary to put a radial and the femoral monitoring in this patient. Cerebral monitoring is done in the form of NIRS, near infrared red spectroscopy, bispectral index, and ONSD. The intraoperative goals should be maintained to maintain a MAP of more than 70 millimeters of mercury. BISH should be maintained in the range of 40 to 60 to ensure adequate anesthetic depth. NIRS should be maintained in the range of 60 to 75. An output of 0.5 ml per kg per hour should be maintained. Serum sodium, same should be maintained in the range of 145 to 150. Any kind of acidosis or hypovolemia should be avoided, and normothermia, normocapnia, normovolemia should be maintained. Blood products should be transfused based on the TEG. Now, during the surgery, all the 3 phases of surgery, liver transplant being a very prolonged procedure, it leads to a lot of fluid shift in the body, and all the phases of surgery are prone to cause hypovolemia and hypocoagulable state, which will invariably lead to decrease in the cerebral perfusion pressure. So in the dissection phase, hypovolemia and hypocalcemia can cause decrease in the cerebral perfusion pressure. Hypothermia is also hypothermia can also occur during the dissection phase due to rapid sometimes if the blood is given rapidly or over a short time, hypothermia can occur, which can lead to cardiac depression and arrhythmias. Hypocalcemia can also occur due to massive transfusion, which can also lead to myocardial depression, which can further lead to decrease in the cerebral perfusion pressure. And hypomagnesemia also can cause cardiac arrhythmias. During the anhepatic phase, the hemodynamic instability is mainly due to decrease in the venous return. In this stage, the liver is taken out, so there is decrease in the venous return as the portal vein is also clamped. And the other thing is, before starting the reperfusion, the IVC is either partially clamped or totally clamped, depending upon which technique is used for implantation. In the classical technique, the total cable replacement is done, in which the total IVC is clamped, in which there is almost 50% reduction in the venous return from the lower limbs. So there are more chances of hemodynamic instability leading to cerebral hyperperfusion in this kind of patients. And in the piggyback technique, we have a safe margin in which only a side clamp is applied to the IVC. So there are less chances of hemodynamic instability, but however, there are chances of hypertension in this stage also. Also at the end of this stage, when the clamps are opened, hemodynamic instability can occur. Also, the hypocalcemia, hypomagnesemia, hypothermia, hypoglycemia are more intense in this phase due to the total loss of hepatic function. And in the neohepatic phase, cerebral ischemia is more common due to sudden hemodynamic fluctuation. There is sudden release of acidotic, hypothermic and potassium-rich blood in the circulation, along with vasoactive agents from the blood and the spankling circulation, as the portal vein is clamped till this time actually. Coming on to the weaning. Weaning is a transition process from total ventilatory support to spontaneous breathing. The best approach to start weaning in all patients is to question every day, why are this patient receiving mechanical ventilation? do they require a current level of support, or do they still need, and the third is, do they still need to be mechanically ventilated? Now, before we start the weaning process, we have to assess for the readiness of the weaning in these patients. So this is divided into clinical assessment and the objective parameters. Clinical assessment, there should be adequate cough reflex in this patient after stopping the sedation. There should be absence of any excessive tracheobronchial secretion in these patients, and there should be a resolution of the acute phase of the disease for which the patient was intubated. Objective parameters include clinical cardiovascular and metabolic stability, adequate oxygenation, which includes a saturation of more than 90% on a FiO2 of less than 0.5 with a PF ratio of more than 150, and a PEEP should ideally be less than 8 before we start to wean these patients. There should be adequate pulmonary function with the absence of any tachypnea in the form of respiratory rate less than 35 and a tidal volume of more than 5 ml per kg. There should be no significant respiratory acidosis, and the patient should be adequately awake, and the mentation should be optimum without sedation. Initiation of weaning. Now, in this two kinds of patients, we all encounter two kinds of patients: the patients who have spontaneously recovered without transplant, and the patients who have underwent transplant and needs to be weaned post surgery. So in patients who have spontaneously recovered, the metabolic parameters needs to be assessed. There should be a definitive downstream of ammonia. There should be normalizing lactate. There should be normal values of ONSD. There should be an improving liver function in the form of declining INR, liver enzymes, and bilirubin. And there should be no requirement of organ support in the form of CRRT, vasopressors, or plasmapheresis. Post-transplant, there should be adequate graft function in this patient. Again, there should be declining or normalizing INR and liver functions. There should be normal liver imaging and normal flows in the hepatic vessels on ultrasound, adequate urine output, stable hemodynamics, adequate neuromuscular recovery, no significant hemorrhagic drain, and chest X-ray should not show any signs of fluid overload. Now, there are some criteria for failed weaning in which the patients might not be weaned successfully. Like the objective parameters, there are the objective and the clinical parameters. In the clinical parameters, the patients might be agitated or anxious after the surgery because the cerebral edema is not fully subsided. There must be a depressed mental status in these patients because of the persistent hyperammonemia or cerebral edema. There might be diaphoresis also. Also, respiratory wise, there might be increased evidence of increased and labored breathing. There might be increase in the accessory use of the muscles, facial signs of distress, and dyspnea. And objective parameters is basically a hypoxia of PaO2 of less than 60 millimeters of mercury or FiO2 of more than 0.5. There can be a hypercarbia due to hypoventilation. There might be acidosis with a pH of less than 7.2. The rapid shallow breathing index might be more than 105 breaths per minute per liter. And also there might be hypertension or hypotension or any change in the blood pressure or heart rate more than 20% from the baseline. In these kind of patients, we have to restart the sedation, assess for the causes of failed weaning, correction of the cause, and reattempt next day if there is no contraindication present. Now, there are some common causes of prolonged weaning in this kind of patients. The most common are the respiratory causes, in which there can be a reduced compliance or increased resistive load. Reduced compliance might be in the form of any infective pathology like pneumonia, cardiogenic or non-cardiogenic pulmonary edema, pulmonary hemorrhage due to coagulopathy, or diffuse pulmonary infiltrates due to any secondary bacterial or fungal infection. Increased resistive load, because it could be because of the endotracheal tube in situ. Since these patients are intubated for a longer period of time, there might be a glottic edema, and also there might be increased airway secretion due to sputum retention. The other causes are the cardiac causes, in which there is if there is any cardiac dysfunction prior to the illness, or any increase in the cardiac workload leading to myocardial dysfunction due to increased metabolic demand, or any unresolved sepsis. Now, in this subset of patient, also there might be a persistence of cerebral edema as to how the exact time frame as to how much time the cerebral edema takes to settle down in the patient of post-liver transplant in ALF is not clear, but sometimes it resolves in 2 to 3 days, and sometimes it might take up to a week to resolve for the edema to settle down. There also might be signs of raised ICP like the Cushing's reflex, bradycardia, hypertension, or increase in the ONSD in these patients. This may be because of the delayed graft function or graft failure. Also, these patients might be delirious or anxious or depressed in the post-operative period. Another important cause of delayed weaning in these patients is neuromuscular recovery. Most of the patients, since they are ventilated for a long time, they have they can have neuromuscular weakness in these patients. There can be a depressed central drive due to metabolic alkalosis or the delayed clearance of sedative medications in this kind of patients, or there may be peripheral dysfunction in the form of critical illness, neuropathy or myopathy in this patient. Patient might also be difficult to wean if the patients are malnourished, and also in some patients there is ventilator associated ventilator induced diaphragmatic dysfunction. This can be checked nowadays with ultrasound, and diaphragmatic excursion can be checked with the use of ultrasound. A movement of more than 2 centimeters rules out the diaphragmatic dysfunction in this kind of patients. And also lastly, we should always remember graft related issues in this patient in the post-operative period. These are the few studies which have been done. First was done by Dr. Pamecha sir in our institute. It included a number 61 included 61 patients, and in these patients the outcome of emergency LDLT for acute liver failure patients have been studied. In this the outcomes were the brain edema, presence of SIRS, long in anhepatic phase, culture positivity. They were the significant factors predicting early mortality after LDLT and also for prolonged mechanical ventilation in the post-operative period. Another study which was done by Naifu et al., it included a total of 128 patients. In this, they studied the incidence and risk factors of prolonged post-operative mechanical ventilation in children who underwent liver transplant. In this, they found a young age of the patient, pre-operative hypocalcemia, and increased duration of surgery are the independent predictors of prolonged post-operative mechanical ventilation following orthotropic liver transplant. The other study done by Lee et al., in this, they studied the clinical effects of prolonged post-operative post-transplant mechanical ventilation and identified the risk factors for the same. They came up with the results of pre-operative hepatic encephalopathy grade 3 or more, intraoperative blood loss, blood pressure fluctuation, and oliguria were found out to be independent risk factors for prolonged post-operative mechanical ventilation. So here in our hospital, we follow an algorithm. This is thanks to Dr. Prashant sir, this is mainly followed in our liver coma ICU. Once the patient is assumed fit to be weaning, a spontaneous breathing trial is given to the patient. The patient is put on pressure support ventilation for 30 to 60 minutes. We start with a pressure support of around 12 and a PEEP of 6 millimeters of mercury. Gradually, the pressure support is decreased every hourly depending upon the response of the patient. An ideal pressure support of 6 to 8 centimeters of mercury and a PEEP of 5 should be there before the patient is planned for extubation. In the meanwhile, the patient is monitored for patient's heart rate, MAP, saturation, EtCO2 and sensorium are monitored. After that, if we are able to bring down the pressure support to 6 to 8 and a PEEP of 5, we give the patient a TP's trial of 6 to 8 liters of oxygen for around 1.5 to 2 hours. And after this, if the patient has a good cough reflex, minimal airway secretion, adequate sensorium to protect his or her own airway, extubation is done, and after that post-extubation care is taken. If the patients are not extubated, a patient has to be put on controlled mechanical ventilation again. They have to reassess after 24 hours, and if subsequent 2 to 3 spontaneous breathing trials are failed, we should always consider for early tracheostomy in these patients. Now coming on to the post-transplant patient in the post-transplant patient in the transplant ICU. Post-surgery, the patients are electively sedated and ventilated for 36 to 48 hours. The patients who have, since these patients have, most of the patients are intubated in the pre-operative period and they have a HE grade of 3 or 4. It takes time for the cerebral edema to settle down in the post-operative period and the graft function to pick up. So these patients are ventilated for around 48 hours. During this time, the graft function, ABG, X-rays are monitored. Once 48 hours are over and the graft function is adequate, the sedation is stopped and the patient is assessed for awakening and neuromuscular recovery. Again, if the patient is ready for weaning, the patient is put on pressure support ventilation for 1 to 2 hours, and during this time the patient's vitals are monitored, mechanics, respiratory mechanics and ABG is monitored. If the patient is okay, then the patient is extubated, post-extubation care is given. Intensive chest and limb physiotherapy is done, because most of these patients, since they are ventilated for a prolonged period of time, they might have neuromuscular weakness. Inceptive spirometry is done, and adequate Anil JCI is given in these patients, because unlike CLD patients, most of these patients, they do complain of pain, and so Anil JCI is given in the form of narcotics. like fentanyl in these patients. If the patients are not, we are not able to wean off the patient, then we are again reassess the patient after 12 to 24 hours. A tracheostomy is considered after 3 to 5 days of failed weaning, and after once the tracheostomy is done, an aggressive chest and limb physiotherapy is started with regular pulmonary toileting, muscle strengthening exercises are done, and adequate nutrition is started. IL-based data. I'd like to thank Dr. Sovina for this data collection. This was her thesis topic. In this, we had collected data of ALF patients who underwent liver transplant from 2010 to 2021. A total of 76 patients were included in the study, and they were divided into two groups of prolonged post-operative mechanical ventilation and patients who were weaned off early. The criteria for prolonged post-operative mechanical ventilation was if the patients were not, we were not able to extubate the patient within 7 days after the surgery, they were put into prolonged mechanical ventilation group, and the other into non-prolonged mechanical ventilation group. A total of 29 patients were included in the prolonged mechanical ventilation group, and the perioperative risk factors was studied which could predict the need for prolonged post-operative mechanical ventilation in these patients undergoing emergency LTLT. Also, the incidence of prolonged ventilation in the acute liver failure patient, total duration of ICU stay, total duration of hospital stay, and the 28-day mortality was studied. The results were incidence of post-operative mechanical ventilation in acute liver failure was found to be around 37%, and the perioperative risk factors for developing prolonged mechanical ventilation included a pre-liver transplant duration of mechanical ventilation exceeding more than 27 hours, more than or equal to 1500 ml of blood product transfused intraoperatively, lactate level of 6 or more than 2 hours post-reperfusion, and sepsis occurring within 5 days of transplant had a 9 times more risk of prolonged post-operative mechanical ventilation. Prolonged mechanical ventilation was associated with increase in the ICU stay and the hospital stay, and the incidence of mortality was around 57% in this patient, and the overall survival rate in the ALF in the patients undergoing LT was found to be around 65%.